Hello students. In today's session we are going to discuss about sympathetic nervous system and drugs which are acting on sympathetic nervous system. In previous sessions of autonomic nervous system, you have learnt about parasympathetic system. You all know that parasympathetic nervous system fibers are arising from the craniosacral region of the spinal cord. Exact opposite to that, sympathetic nerve fibers are arising from the thoracolumbar region of the spinal cord. The preganglionic fibers will end here at the ganglia level. The ganglia of the sympathetic system are lying just parallel to the spinal cord. The postganglionic fiber arises from here and they again form a ganglia which is near to the end organs. These ganglia are celiac ganglion, superior mesenteric ganglion, inferior mesenteric ganglion, cardiac and pulmonary plexuses, and ultimately they will be supplying heart, lung, gastrointestinal tract and genitourinary system. The details of anatomy and physiology of the autonomic nervous system and sympathetic system has been taught to you in first year, that is in anatomy and physiology lectures. So we are not going into very much details of the anatomy and physiology. We will be more focusing on the pharmacological aspects which are related to the sympathetic system. To understand the pharmacology of sympathetic system, we should first understand the neurotransmission into the sympathetic system. You all know that the nerve fibers which are secreting acetylcholine at the postganglionic area are called as parasympathetic fiber, which are predominantly present in cardiac and smooth muscles, gland cells and nerve terminals. The parasympathetic fibers which are ending into the sweat gland, they are though releasing acetylcholine, they are considered as a sympathetic stimulation. Majority of the sympathetic fibers which are end at the cardiac and smooth muscles, gland cells, nerve cells, renal vascular smooth cells, they release either epinephrine or norepinephrine at the end point. So nerve fibers which are secreting either epinephrine or norepinephrine at the end point are considered as a sympathetic nerve fibers. Let's understand adrenergic neurotransmission first. Adrenergic system is a system which prepares the individuals for fight or flight reaction. The adrenergic system is restricted to the sympathetic division of the autonomic nervous system only. Noradrenaline is the major neurotransmitter released at postganglionic sympathetic sites except sweat glands, hair follicle and vasodilator fibers. While adrenaline is the major neurotransmitter released into the adrenal medulla, it is also acting as one of the transmitter in brain. Dopamine is another important adrenergic transmitter which is released mainly into basal ganglia, limbic system, CTZ and pituitary. Now we see the synthesis and other steps of the neurotransmission which are related to the adrenergic system. The neurons which are synthesizing and releasing the adrenaline or noradrenaline, they are called as adrenergic neuron. Here you can see that this is the preganglionic fiber. Here is the synaptic cleft and here is the post-junctional membrane. The synthesis of adrenaline starts with the tyrosine. Tyrosine, which is available as amino acid from the diet, is transported actively into noradrenergic ending and is converted to DOPA by enzyme tyrosine hydroxylase. So tyrosine hydroxylase is the first enzyme responsible for conversion of tyrosine into DOPA. Now this DOPA is converted into dopamine by enzyme DOPA decarboxylase. Here the DOPA decarboxylase enzyme acts and convert the DOPA into dopamine. This dopamine is transported into the vesicle or it is converted into norepinephrine. The conversion of dopamine into norepinephrine is carried out by the enzyme beta hydroxylase. Most of the regions of the adrenergic nervous system are having norepinephrine as neurotransmitter. But in adrenal medulla, this norepinephrine is further converted into epinephrine which is the major neurotransmitter into adrenal medulla. Now, whenever this action potential comes or steps of neurotransmission starts and calcium ion gets inside the cells, it will cause docking of the vesicles. The vesicles which are filled with the noradrenaline, they come and adhere to the membrane, and along with the entry of the calcium, this vesicle will release norepinephrine, ATP and other co-transmitter into the synaptic cleft. Now this norepinephrine is released into the synaptic cleft and it is ready to act on the post-junctional receptors and carry out all other actions for which it is meant. The transmitter then activates the post-junctional receptor which are located into the membrane. For the adrenergic system, they are adrenoceptors. For other system, they can be different. Once the action is initiated and desired action is carried out, then how the action of norepinephrine is terminated? You have learnt into the transmission of the cholinergic system also that there are 3 uptake mechanisms. The major mechanism responsible for the termination of neurotransmission action is uptake 1, that is the back diffusion of the norepinephrine into the pre-junctional neuron. It is the most important action and major portion where norepinephrine after completing the action will be taken up by the axonal cells. Other mechanism through which the action of norepinephrine terminated is the diffusion into surrounding tissue, that is uptake 2. Here after going into surrounding tissue, it is inactivated by the enzyme COMT and it is converted into normetanephrine. The norepinephrine which is taken back into the vesicles will be further metabolized by the MAO enzyme, that is monoamine oxidase enzyme, and it will be responsible for breakdown of norepinephrine into its active metabolites. Apart from the post-junctional receptors, there are certain pre-junctional receptors also. These pre-junctional receptors are also having important role in regulation of the neurotransmitter release. When we stimulate the alpha-2 adrenoceptor which are located pre-junctionally, there will be inhibition of the further release of the norepinephrine. So when these alpha-2 receptors are stimulated, the release of norepinephrine is inhibited. And same way as the pre-junctional or presynaptic beta-2 receptor are stimulated, then norepinephrine release is stimulated because they are auto-stimulatory. So here we have to remember that presynaptic alpha-2 receptors are auto-inhibitory and presynaptic beta-2 receptors are auto-stimulatory. So going into little more detail of metabolism of the neurotransmitters. All adrenergic neurotransmitters are mainly metabolized by monoamine oxidase enzyme, which is mainly present into the CNS, responsible for termination of action of adrenergic neurotransmitter within CNS. While COMT enzyme, full form is catechol O-methyltransferase, which is specially present into liver and other peripheral tissue, and it is responsible for the termination of action of the adrenergic neurotransmitter into peripheral nervous system. Here is the metabolic pathway. Either adrenaline or noradrenaline, they will be acted upon by the COMT enzyme or MAO enzyme based on the site. They all will be converted into DHMA. DHMA stands for dihydroxymandelic acid. This dihydroxymandelic acid is an unstable product and it will be converted into vinyl mandelic acid. The other pathway is noradrenaline is converted into normetanephrine and adrenaline is converted into metanephrine, and both of them will be further converted into vinyl mandelic acid, which is considered as an end product of the neurotransmission into adrenergic system. Sometimes to know the concentration of adrenaline and noradrenaline into blood, concentration of vinyl mandelic acid into urine is also measured. This vinyl mandelic acid will be converted into glucuronide and sulfate conjugate and then it will be excreted fast from the urine. So this is how the adrenergic neurotransmitters are metabolite. Now we see the drugs which are affecting the adrenergic transmission. Till now you have learned that adrenaline, noradrenaline, dopamine, they all are synthesized from the tyrosine. Tyrosine enters the cell by active process, which is metabolized by tyrosine hydroxylase enzyme and converted into DOPA. DOPA is converted into dopamine. That dopamine is converted into norepinephrine by DOPA decarboxylase enzyme. This is norepinephrine is stored into the vesicles. At the time of neurotransmission or activation of the nerve membrane by action potential, whenever calcium entry occurs, docking of vesicle occurs. This vesicle will release the stored neurotransmission, that is norepinephrine, ATP and phosphorus, and they will be released into the synaptic cleft, which is causing action on the post-junctional receptors. Once the action is carried out, they will be taken back up by the pre-junctional neuron, as well as they will be going into surrounding tissue by the process of diffusion. This is the whole process of adrenergic neurotransmission. Now we see the drugs are acting at what levels. First is synthesis blocker. Here the drug is alpha methyl P tyrosine, that is also called as metyrosine. It is the drug which inhibits the tyrosine hydroxylase enzyme. So inhibition of tyrosine hydroxylase enzyme would lead to no synthesis of dopamine and further synthesis is inhibited. It is also called as synthesis blocker. Another type of blockers or the drugs are axonal uptake blockers. These drugs are cocaine and desipramine. They will be inhibiting the uptake of norepinephrine through the pre-junctional neuron. So whenever cocaine, tricyclic antidepressant like desipramine, they are present, they will be inhibiting the uptake mechanism of norepinephrine. So back uptake into the neuron does not take place with the norepinephrine, which would mean that norepinephrine will remain into the synaptic cleft for longer period of time and they will enhance the action of norepinephrine. Another type of blocker is vesicular uptake blocker. Once the norepinephrine is taken back into the presynaptic neuron, it will be further stored back into the vesicle by the vesicular monoamine transferase. This vesicular monoamine transferase can be inhibited by drugs like reserpine, and once these are blocked, norepinephrine cannot be taken back into the vesicle. So norepinephrine will remain into the presynaptic neuron into the cytoplasm, where it is metabolized by the MAO enzyme. So over a period of time, they will decrease the action of norepinephrine. They are also called as norepinephrine depleter drugs. Another drug is release blocker. Guanethidine and bretylium are the drug. They will be inhibiting the docking of vesicles and they will not allow the release of norepinephrine to take place. They are also called as release blocker. There are certain drugs which causes norepinephrine release like tyramine and ephedrine. These are the drugs, they will be stimulating the release of norepinephrine. Then there is something called as MAO inhibitor and COMT inhibitor. As stated earlier, MAO and COMT are the enzyme which is responsible for metabolism of the adrenaline and noradrenaline. So when blocker of these enzymes are given, metabolism of adrenaline and noradrenaline does not take place, which would lead to enhancement of the action of adrenaline and noradrenaline. And lastly, but not the least and most useful therapeutic agents are receptor agonist and antagonist. So these are the receptors, either drug which is stimulating the receptors or inhibiting the receptor, which are most commonly used into therapeutics. So this is the nutshell of listing of all the drugs which are acting on adrenergic neurotransmitter. Just to revise them fast, first is the tyrosine hydroxylase blocker, that is metyrosine, and it will inhibit the synthesis of the norepinephrine. Secondly, there is an axonal uptake blocker, that is neuronal blocker, cocaine and tricyclic antidepressant, they will inhibit the uptake 1 mechanism and prolong the action of norepinephrine into synaptic cleft. Third category is vesicular monoamine transferase inhibitor or vesicular uptake blockers, that is reserpine. And because the norepinephrine is not taken back or stored into vesicle, it will be remain into the synaptic cleft, which is metabolized, where it is metabolized by MAO or COMT enzyme. There are certain drugs which are also cause inhibition of release, that is bretylium and guanethidine. There are certain drugs which will stimulate the release, that is tyramine and ephedrine. You can directly give the metabolizing enzyme blockers like MAO inhibitor and COMT inhibitors, or you can directly go for the receptor agonist and antagonist, which are the most commonly used therapeutic agents. This is the list of adrenergic receptors. To know the drugs which are acting on the receptor, we should first know which receptors are there for adrenergic system. In adrenergic system, there are basic two types of receptors, alpha receptors and beta receptor. Alpha receptor is further subdivided into alpha 1 and alpha 2 receptors, while beta receptors are having three subunits, that is alpha beta 1 receptor, beta 2 receptor and beta 3 receptors. All the receptors alpha and beta, they are of G protein coupled receptor variety. Alpha 1 receptors are located into vascular smooth muscle, genitourinary smooth muscles, intestinal smooth muscles, on heart and liver. And their basic function is contraction of the vascular smooth muscle and genitourinary smooth muscle, while they relax the intestinal smooth muscle. On heart, they increase the inotropic action and excitability, while in liver, they causes glycogenolysis and gluconeogenesis. Alpha 2 receptors are located on pancreatic beta cells, platelet, nerve fibers and vascular smooth muscles. Their basic actions are action on stimulation of alpha 2 receptor of pancreatic beta cell would lead to decrease in the insulin release. It will cause platelet aggregation. It will cause decreased norepinephrine release, which is presynaptically located, and stimulation of alpha 2 receptor which are located onto vascular smooth muscle would lead to contraction of the smooth muscles. So alpha 1 receptors are located mainly on the heart, vascular smooth muscle and genitourinary smooth muscle and liver, while alpha 2 receptors are mainly present on the pancreas, vascular smooth muscle, platelet and nerve fibers. You have to remember location of each receptor and the basic action which is produced by their stimulation. Now we come to beta receptors. Beta 1 receptors are located on heart and JG cell of kidney. On the heart, they causes increase on the chronotropy, inotropy, increased conduction velocity, and while stimulation of beta 1 receptor of JG cells of kidney would lead to increased renin release. Beta 2 receptors are located on the smooth muscle, liver and skeletal muscles, and they will cause relaxation of smooth muscles. In the liver, they causes glycogenolysis and gluconeogenesis, and in the skeletal muscle, they cause glycogenolysis and increased potassium uptake. Beta 3 receptors are specifically located on adipose tissue only, and they have important role in fat metabolism, and they are stimulation of beta 3 receptor would lead to lipolysis. So beta 1 receptors are located on heart and JG cells of kidney. Beta 2 receptors are located on all the smooth muscles, liver and skeletal muscles, and beta 3 receptors are located on adipose tissue. Now we see the activity of some adrenergic agonists on different receptors. Adrenaline, which is a prototype of adrenergic drug, it is agonist at all the adrenergic receptor, which means it is agonist as alpha 1, alpha 2, beta 1, beta 2 and beta 3 receptors. Noradrenaline will act on alpha 1 receptor, alpha 2 receptor, beta 1 and beta 3. Noradrenaline does not act on beta 2 receptors. Isoprenaline will act on beta 1, beta 2 and beta 3 receptors only. It does not act or very minimally act on alpha receptors. Dopamine will act on dopamine 1, dopamine 2 receptors as well as alpha 1 receptors and beta 1 receptors, but it does not act on beta 2 receptors. While dobutamine is an agent which is specifically acting on beta 1 receptors only. So these are the 5 major neurotransmitters or drugs which you need to remember for adrenergic system. Adrenaline will act on all adrenergic receptor, that is alpha 1, alpha 2, beta 1, beta 2, beta 3. Noradrenaline will act on all the adrenergic receptors except beta 2. Isoprenaline will be acting on beta 1, beta 2 and beta 3 receptors with no effect on alpha receptor. Dopamine will act on dopamine 1 and 2 receptor as well as it will be acting on alpha 1 and beta 1 receptors but no beta 2 action. While dobutamine is a beta 1 selective agent. Now we see the classification of adrenergic drugs. Adrenergic drugs can be classified by different ways. First we see the chemical classification. Chemical classification is based on the chemical structure of the compounds. Based on the chemical structures, these agents are divided into catecholamines and non-catecholamines. Catecholamines are the drugs which are having catechol nucleus in their chemical structure, which include adrenaline, noradrenaline, dopamine and isoprenaline. While non-catecholamine drugs are ephedrine and amphetamine. They can be classified based on the mode of action, according to which directly acting agents are adrenaline, noradrenaline, isoprenaline, salbutamol, xylometazoline, etc. Drugs which are acting indirectly by releasing the norepinephrine from the nerve terminal, that is tyramine and amphetamine, and there are certain drugs which are having mixed action of direct and indirect both, that is ephedrine. So adrenergic agonist can be divided into direct acting, indirect acting and mixed acting. Direct acting and they can be further divided based on the receptor selectivity. Selective agents means drugs which are selecting for alpha 1 receptor are phenylephrine, agonist of alpha 2 receptor, that is clonidine, agonist of beta 1 receptor is dobutamine, agonist of beta 2 receptor is terbutaline. Non-selective agents, that is the drugs which are acting on alpha 1 and alpha 2 both, oxymetazoline, beta 1 and beta 2 both, isoprenaline, epinephrine acts on alpha 1, alpha 2, beta 1, beta 2, norepinephrine acts on alpha 1, alpha 2 and beta 1. Indirectly acting drugs can be divided into releasing agents, uptake inhibitors, MAO inhibitors and COMT inhibitors. Releasing agents are amphetamine and tyramine. Uptake inhibitors are cocaine and desipramine. MAO inhibitor is seligene and COMT inhibitor is entacapone. And last but not the least, that is mixed acting agent ephedrine, which is directly acting on alpha 1, alpha 2, beta 1 and beta 2 receptor, as well as it is acting as a releasing agent. So here is the classification of adrenergic agonist. They are first divided into direct acting, indirect acting and mixed acting, and based on the receptor selectivity they can be selective and non-selective. Last way of classifying the adrenergic agent is therapeutic classification, which is more useful clinically. Vasopressor drugs, which means the drugs which can increase the blood pressure, are epinephrine, norepinephrine, dopamine, phenylephrine, methoxamine and mephentermine. Cardiac stimulants are adrenaline, noradrenaline, dobutamine, isoprenaline. Drugs which are stimulating the CNS are ephedrine and amphetamine. Drugs which dilate the bronchi or bronchodilators action are salbutamol, salmeterol, terbutaline. Nasal decongestant drugs are xylometazoline, oxymetazoline and pseudoephedrine. Appetite suppressants are fenfluramine, dexfenfluramine. Uterine relaxant drugs are vitodrine, isosuprine. Mydriatics are phenylephrine and ephedrine. Therapeutic classification is based on the therapeutic use for which these agents are clinically useful. Now we start with the discussion on adrenaline. Adrenaline is a prototype of adrenergic drugs. It is endogenously released as a hormone from adrenal gland, as well as it is given exogenously as a drug also. And as you all know, adrenaline acts on which receptors? It is acting on alpha 1, alpha 2, beta 1, beta 2 and beta 3 receptors. In short, it is acting on all adrenergic receptors. So what are the actions of adrenaline? Can you think? What are the actions of adrenaline? Whenever adrenaline is released in large quantity, like you are in a frightening situation, like you are walking on the street and dog is running behind you, or suddenly you are forcefully kept in a situation where you feel very anxious and not comfortable, then your sympathetic system gets activated. And it would lead to all the actions which are required for coping of that stress. That is called as flight or fight reaction. Here, first will be, because you have to run very fast from that situation, your eyes will be dilated. Under the influence of sympathetic stimulation, pupillary dilatation occurs so that you can see very far objects also. More light enters into the retina. For more heart, you have to run. So you need increased rate of heart rate, increased force of contraction, increased blood pressure, means your heart starts pumping fast. At the time of anxiety and stress, your heartbeat increases. The energy is required, so the fat tissue, there will be lipolysis. The fat is released, lipolysis occur and it will be converted into energy which is used. Fatty acid liberation takes place. On the bladder, while you are running from a dog which is running behind into the street, you need to contract or you need to hold the urine. So sphincter tone of the bladder muscle increases and detrusor muscle tone decreases. You need more energy into the skeletal muscles because you have to run. So blood flow to the skeletal muscle increases and glycogenolysis is also more. Peristalsis into GIT decreases, or the sphincter tone of the GIT increases and blood flow to GIT decreases because more blood flow will be diverted towards the skeletal muscle. And while you are running, you should not be comfortable with the bowel movement. So the peristalsis decreases and all the sphincters of the GIT constricts. In the liver, there is glycogenolysis. You are running, you need more energy, you need more glucose. So there will be glycogen breakdown from the liver which would lead to glycogenolysis and glucose release is more. In the skin, there is increased perspiration. Though the innervation is cholinergic, under the influence of sympathetic system, there will be more sweating. You need more air because you have to run very fast. You need more amount of oxygen to carry out all the bodily function. So bronchus gets dilated, you get more air. Your saliva becomes little and viscous, so that your mouth becomes dry. Your CNS becomes very active, alert, your drive increases, alertness increases. In nutshell, you just have to remember that you are in a frightening situation and you have to run. Now assume what all actions are required. They are the actions of adrenergic stimulation. In a simpler term, they are the actions produced by the adrenaline. This diagram will help you in remembering that actions. Let's go into further more details of pharmacological action or the core pharmacology of adrenaline. What are the actions of adrenaline on the heart? Actions of adrenaline on the heart are mainly mediated by beta 1 receptor, which would lead to increase in the heart rate. Increase in the heart rate increases, automaticity of SA node increases, which would lead to tachycardia. Force of contraction increases, which would lead to increase in the stroke output and increase in the cardiac output. Ultimately, cardiac work and oxygen consumption by the heart both increases. It will also increase the conduction velocity through the heart. So conduction through the AV node, bundle of His, atria, ventricle, all the electrical portions of the heart gets more conduction. So in nutshell, heart is stimulated. Rate increases, conduction increases, force of contraction increases, cardiac output increases, which would lead to increased oxygen requirement and increase in the blood pressure. What is the action of adrenaline on blood vessels? Vasoconstriction occurs at the blood vessels, which is mainly mediated through alpha-1 and alpha-2 receptors. The blood vessels which are located into mucous membranes, skin and renal tissue will be vasoconstricted. But the blood vessels which are located into skeletal muscle, liver and coronaries, there would be vasodilatation because predominant receptor located here are beta-2 receptor. If you remember from the previous slides, we have discussed that basic action of alpha receptor stimulation is vasoconstriction. Alpha 1. Basic action of beta 2 receptor stimulation is vasodilatation. Vasodilatation of the renal and coronary arteries also occurs through dopamine 1 receptor. Action is marked on the arterioles and precapillary sphincters, and larger arteries and veins are affected at higher doses only. Now, effect on the blood pressure. What is the effect of adrenaline on blood pressure? This is the systolic blood pressure. It increases. Diastolic blood pressure will be decreases at low doses, but over a period of time when you give high doses, there will be rise in blood pressure. Pulse rate will be increased with the epinephrine and peripheral resistance will be decreased. As compared to noradrenaline, noradrenaline does not act on beta-2 receptor. So vasodilatation does not take place. So there will be no fall in diastolic blood pressure. Noradrenaline will cause increase in both systolic and diastolic blood pressure, and it will cause profound increase in the vasoconstriction because of the predominant action on alpha receptors. Here the fall in blood pressure or peripheral resistance is mainly because of the beta-2 receptor. This beta-2 action is missing here and there will be increase in the peripheral vascular resistance. Pulse rate will be stabilized or little bit lower because of the reflex bradycardia. While isoprenaline, there will be little rise in the blood pressure. There will be fall in the diastolic blood pressure, peripheral vascular resistance drastically fall, and pulse rate will be increased drastically. So this is the comparison of epinephrine, norepinephrine and isoprenaline regarding their action on blood pressure. Now we move to the next action, that is actions on the bronchial muscles. There will be dilatation of the bronchial muscle and the mucosa of the nasal and other tissue will be decongested because the constriction of that mucosal blood vessel occurred under the influence of alpha-1 receptor. What is the action on eye? The pupillary dilator or radial muscle of the iris will be contracted with alpha-1 action, which would lead to mydriasis. There will be reduced aqueous humor formation and constriction of the capillary vessels. Reduced aqueous humor formation is mainly under the influence of alpha-1 receptor. There will be vasoconstriction into the eye with the alpha-2 receptors. There will be reduced secretion from the ciliary epithelium also. They increase the uveoscleral outflow and reduce intraocular pressure. So ultimately adrenaline causes decrease into the intraocular pressure of eye. What is the action on GIT? They decrease the tone and motility of the stomach and intestine. The direct action is mainly because of the beta-2 mediated smooth muscle relaxation, and indirect action is reducing the release of acetylcholine, which is under the influence of presynaptic alpha-2 receptor. They will also cause closure of all the sphincters of GIT mediated by alpha-1 receptor, and there will be decreased salt and water influx into the intestinal lumen, which is mediated through alpha-2 receptors. Action on salivary glands. There is thick and very little secretion, mainly because of the vasoconstriction produced by alpha-1 receptors. What is the action on uterus? Non-pregnant uterus will be having more alpha-1 dominant action as compared to beta 2 and it would lead to contraction. While in pregnant uterus, beta 2 presentation is more as compared to alpha 1, which would lead to relaxation of the uterus. So more use of adrenaline on the pregnant uterus would lead to relaxation of the uterine muscle and chances of abortion are high. Action on urinary bladder. Detrusor smooth muscle relaxation occur because of the beta 2 action. Closure of sphincters and contraction of the trigone occurs because of the alpha 1 action, and there will be retention of urine. What is action on the skin? There is secretion of the sweat from the sweat glands, mainly M3 receptor, and there is piloerection because of the alpha 1 receptors. In the CNS, they produce this restlessness, apprehension, and they decrease sympathetic outflow, which is mediated by alpha 2 receptors. What is action on kidney? Increase in the tone and motility of the ureter, which is alpha 1 mediated, and also there is a beta 1 mediated renin release from the juxtaglomerular cells of the kidney. On skeletal muscles, they facilitate the neuromuscular transmission by alpha 2 receptor, which would lead to tremors, which is mediated by beta 2 receptors. They also cause inhibition of histamine release from the mast cells. It will also cause uptake of potassium from the extracellular fluid to intracellular fluid. So plasma potassium concentration falls little bit. Metabolic actions of adrenaline are mainly action mediated through beta 3 receptor is lipolysis, which is present on adipose tissue. Action on the liver will produce glycogenolysis and gluconeogenesis, mainly by beta 2 receptor, which would lead to hyperglycemia in the blood. So it is dangerous for diabetic patients. Skeletal muscle and heart, there will be glycogenolysis and ultimately lead to hyperglycemia. Action on the pancreas, alpha 2 mediated decrease in the insulin release, and beta 2 mediated increase in the glucagon release will be there. Ultimately, there is hyperglycemia produced into the blood. Now we see the therapeutic uses of adrenaline. Where we should use adrenaline. As discussed earlier into general pharmacology also, adrenaline is drug of choice for anaphylactic shock. Anaphylactic shock is a condition type 1 hypersensitivity reaction where major mediator responsible for anaphylactic shock is histamine. There is large release of histamine because of the presence of allergen, which would initiate anaphylactic shock. Histamine would lead to syndrome of bronchospasm, mucous membrane congestion, angioedema, severe hypotension, and the patient is having rash and all other symptoms. Drug of choice or life-saving drug here is epinephrine or adrenaline, given as 0.3 to 0.5 milligram. It is available as 1:1000 solution, which is to be administered intramuscularly. Always remember that adrenaline is always given intramuscularly. It is never administered intravenously. If at all you have to give adrenaline intravenously, you have to use 1:1 lakh solution of adrenaline, more diluted version. Otherwise, when you inject adrenaline intravenously, there will be sudden cardiac arrest because heart rate increases. It would lead to cardiac arrhythmia and patient dies on the spot. So adrenaline, though it is a life-saving drug, it should always be given intramuscularly in the concentration of 1:1000 only, and dose is 0.3 to 0.5 milligram. Here adrenaline is acting as a physiological antagonist of histamine. In the anaphylactic shock, histamine is released in the large quantity which has occupied almost all the histamine receptors. So there is no place for antihistaminic drugs to act here. We need a drug which is acting on the different receptor, still producing exactly opposite action, that is physiological or functional antagonist. Adrenaline and histamine are physiological antagonists of each other. That is why in anaphylactic shock, adrenaline is drug of choice. Other use of adrenaline is sudden cardiac arrest. You must have seen in the movies also that adrenaline is given intracardiac and patient suddenly revives, which is little bit more dramatical, but it is true that adrenaline can revive the stopped heart. It is the drug of choice for the treatment of sudden cardiac arrest. Adrenaline can also be useful for local hemostatic agent because of the strong vasoconstriction property. So whenever bleeding occurs, like epistaxis, or while you are operating on the field and you see that capillaries are oozing or bleeding very high, you can use the swabs which are deep in adrenaline to stop that local bleeding. It is also given in combination with local anesthetic. Usually we use lignocaine as a local anesthetic agent. Lignocaine is administered into the local region, either into the nerves or the different planes, to perform small procedures where only local anesthesia is required. But the problem is that lignocaine can be diffused into systemic circulation and action is usually terminated. Adrenaline is here added to the lignocaine to enhance the duration of action of lignocaine. Why so? Adrenaline is a strong vasoconstrictor substance. So whenever lignocaine and adrenaline are injected together, adrenaline will cause vasoconstriction of the blood vessels which are present in that area. Now blood vessels are constricted, they will not be able to absorb lignocaine. So lignocaine will remain into the local field for longer duration of time and you can perform the surgical procedure in your desired time. So action or addition of the adrenaline to the lignocaine is to enhance the duration of action of lignocaine. Now we see the adverse drug effects of adrenaline. Adverse drug reactions are nothing but extension of the pharmacological actions only. So what happens when you give excess dose of adrenaline? There would be restlessness, anxiety, palpitation, tremors and pallor. Increase in the blood pressure and the BP would increase in such a manner that it may lead to cerebral hemorrhage. Increased cardiac work and contractility which would lead to precipitation of the heart attack or ischemic heart disease which we call as angina pectoris. It may lead to cardiac arrhythmia and sudden death also. So because of this dangerous side effect, we should know the contraindications of adrenaline also, which means where you should not use adrenaline. The first contraindication is hypertension. The patient, those who are already hypertensive, they should not be given adrenaline because the blood pressure will be further shoot up, which can be life-threatening for that patient. It should not be given to patients of angina pectoris and myocardial infarction, where the oxygen supply to the heart is already compromised. And by giving adrenaline, it will cause increase in the requirement of the oxygen by the heart muscle, which will precipitate angina pectoris or myocardial infarction. Adrenaline should not be given for congestive heart failure also because the heart is having some problem, structural functional abnormality, because of which it is not working properly in congestive heart failure. By giving adrenaline, you are stimulating that failing heart, which can be more dangerous. It may lead to death of the individual also. Other contraindication is hyperthyroidism because adrenaline acts as a permissive hormone for thyroid action and it will enhance the action of adrenaline as well as thyroid hormone. It should not be given along with tricyclic antidepressant, halothane and MAO inhibitors. Thank you for your patient hearing. I hope you have understood the adrenaline and basic concepts of sympathetic system. If you have any questions, you can ask here in the comment box or you can meet or mail me so that we can clear your doubts. Thank you so much.